This conference will now be
Okay.
recorded.
All right, so where we had left off on Wednesday, we had looked at what happens when we reach the normal end of our red blood cell life cycle, right? The breakdown of erythrocytes into the various products, what we do with those products, all that kind of fun stuff. Where we've got to go, been a long day already. Where we've got to go now is to kind of think about what happens when things don't go according to plan, right? What sorts of problems might we expect to find with regard to erythrocyte pathologies? Right? Probably the one that you are most familiar with as an idea are the anemias, like diabetes or any number of other disorders we'll talk about. It's not one thing, it's a lot of different sorts of pathologies that all get at the same basic problem. So again, an anemia is more of a symptom rather than a disease, I guess is the best way to think about it. And with anemia, basically all this means is that your blood has a problem. It doesn't do a very good job at delivering oxygen to your tissues. And when this becomes a problem for us is when the capacity for oxygen delivery fails to meet our resting needs. Right? When we cannot support a normal resting metabolism with the oxygen that we've got. And so the things that we typically associate with anemias are the things that we associate with being tired, right? So fatigue, generally speaking, comes into that. Feeling short of breath, being very pale, okay? Having pallor, right? And then oftentimes it also accompanies fever-like symptoms, so things like chills. And so these things alone, right, are not particularly diagnostic, right? 90% of the people that you will see in the office of the GP will have all four of those symptoms, right? Most of those people will not be anemic. So in order to diagnose an anemia, then we have to go a little bit further with that. So when we think about what could cause an anemia, we have three basic ways of getting there, three routes to get to being anemic. Blood loss, right? If your blood is on the floor, it's not delivering oxygen to your tissues. Right? A lower than normal rate of red blood cell production, or a higher than normal rate of red blood cell destruction. These last two, remember that we've got to have regular turnover, right? We make about 2 million per second. We destroy about 2 million per second. If either of those two rates are off a little bit, then we end up with some problems. For the first ones, right, blood loss here, fairly straightforward, generally speaking, right? When we think about blood loss, we're thinking usually about a traumatic event, right? Today, you woke up, you said, hell with this, I'm not going to be a nurse, I'm going to juggle chainsaws for a living, and you try it out, and there goes your arm at the elbow, right? That kind of traumatic blood loss. Fairly easy to treat in the short term, I guess. If you don't have any blood, we're going to give you some blood. Right? Obviously, there's going to be more to it than that, but in terms of not treating the anemia or dealing with the anemia, easy to kind of deal with. The other version of this, I would say, significantly more common, and this is going to be the chronic hemorrhagic anemia. And this is going to be the sort of thing that's more like you have a leaky faucet in your house. Right? And one drip at a time might not seem like much until you get your water bill at the end of the month. In this case, leaky faucet is going to be something like an ulcer, right? Or, and I apologize for the thought of this, but it is true, hemorrhoids. Any of those sorts of things, right? Having piles of having bleeding ulcers, little tiny little slow little drips that over time do add up. And so rather than treating you by giving you a whole bunch of extra blood, not what you need, simply going to treat your problem. We're going to deal with your ulcer. We're going to deal with your hemorrhoids. Whatever the drip is, we'll fix that up, and your anemia will go away with it. Simple as that. Another relatively common form of anemia here, and one that fairly prevalent in this part of the country, in Appalachia in general. We see a lot of these iron deficiency anemias. See it in the South also. Generally anywhere that incomes are not great, that corresponds to poor diet, and that corresponds in turn to low amounts of iron in the diet. And so if you lack iron, you can't make hemoglobin. And so on a smear, what that will look like is you'll have relatively small red blood cells, smaller than normal, right, which is what microcytic means. And you'll have red blood cells that are paler than expected, which is what hypochromic is. They'll be paler than you expect because they don't have hemoglobin in them, or at least not as much. And because they don't have as much, they're just going to be smaller. The good side of this, right, is that this again is really easy to treat. You have a lack of iron in your diet, I'm going to give you some iron in your diet. You're taking iron supplements, and that will clear things right up. This again, this is really, really super common. Poverty, pregnancy, poor diet in general, okay, all of these things can lead to these iron deficiency anemias. You'll see a ton of these things in the course of your career. The more pernicious, I guess, forms of anemias are the ones that take sort of the opposite tack, where they destroy red blood cells, or red blood cells themselves fail more often than they normally ought to. Okay? So hemolytic anemias, a couple of different forms that these can take. We think predominantly about them as being genetically linked, so the production of abnormal or faulty hemoglobin. Certainly we'll talk about some of those. A incompatible blood transfusion, where you get the wrong sort of blood. Your body does not recognize it as blood, it only recognizes it as foreign cells, and so your own immune system destroys it. Or various infections can also get into play here in terms of lysing red blood cells. So again, lots of potential problems. Now, typically, when you talk about abnormal hemoglobin, like I said, this is going to be a genetic thing. It's an inheritable disease, right? And generally speaking, with the abnormalcy here, it's a problem with one or more of the globins that come into this. And the end result is that red blood cells themselves, with these abnormal globin chains in them, are fragile. They tend to fracture or break fairly easily. If they lyse, if they break up, they aren't doing you any good. In this part of the world, we don't see a lot of these, but you will see some of it. These are thalassemias. Thalassemias are genetic disorders typically associated with Mediterranean ancestry. So North Africa, Italy, Greece, that part of the world. Okay. Parts of the Levant, I suppose. And with these, typically we actually are missing a globin chain altogether. Sometimes it's there and it just sucks, but oftentimes it's just missing. And we have 3 instead of 4 globin chains. As a result, obviously we lack a little bit of oxygen carrying capacity, right? We're down to 75% of our original normal carrying capacity. The red blood cells themselves, again, are fragile as a result of this. And this can be not really noticeable, or it can be really severe. There are people that are thalassemic and generally don't know it. There are also people that are thalassemic and are in big trouble. So, again, a wide spectrum of potential presentations of your thalassemic diseases here. The other big faulty hemoglobin genetically linked disorder is sickle cell anemia. In sickle cell anemia, we have a type of hemoglobin called hemoglobin S here for sickle. We'll talk about hemoglobin F and hemoglobin A as normal kinds of hemoglobin later on. But hemoglobin S refers specifically to one that are associated with this disorder. And all that is happening here with hemoglobin S is that one amino acid isn't quite right. So the alpha globin is fine, beta globin has one amino acid that's not quite right, and it screws the whole thing up. Okay? And what happens here, the reason that we call it sickle cell anemia, what happens here is that we start to offload oxygen, right? As we go around to the tissues and we deposit oxygen where it's required, that offloading of oxygen, the deoxygenating of the hemoglobin, tends to cause the cell to sickle or to kind of form a crescent kind of shape to it. Okay? And the problem with these crescent-shaped blood cells is that they tend to clump and clog. Right? They catch on each other. They don't slide past each other through smaller passages. They catch and they clump and they block blood vessels. They also oftentimes will easily break as a result of that. And so with the sickle cell anemia here, our issues are typically one of poor oxygen delivery, particularly to the extremities, right, to the hands and the feet, but it can occur anywhere in the body. And in severe enough cases, right, we're going to see sufficiently decreased oxygen delivery to the point of cell and tissue death. Right? So we get pain associated with that. It's excruciating, painful. Now, this is a trait we associate with Black Africans from the malarial belt, so the sub-Saharan region of Africa and descendants thereof, because again, it is genetic and genetically heritable. And the reason that we see this fixed in these populations is that these people are also susceptible to a disease called malaria. And malaria is profoundly problematic in many regions of the world. If we think about the tropics in particular, malaria kills north of 1 million people every year. Right? It's a big deal. And the reason that this is associated with sickle cell is that this particular mutation, when it is one allele, one copy of this is sickled and the other is not, this confers necessarily immunity, right? But defense against malaria. So the trade-off here, right, is that if you get one copy of it, you won't die of malaria. Right? You've got to be dead or not. Right? You're not going to die of it. So that's a pretty big benefit. The downside of this is that if you have two copies of it, then you have sickle cell. And this alone will kill you. It's not great, right? But again, it's still adaptively better than being dead. So it does have a fairly profound, even though it seems like it's a bad thing you wouldn't want, but a fairly profound adaptive significance to this particular genetic adaptation. But like I said, sickle cell is not something we want. Treatments for this have, well, there's really no other way to say this. Colored folk in this country have not always gotten the best treatment. I guess we'll put it that way. And that obviously extends out to medical treatment. Obviously, we know about things like the Tuskegee experiments and all of those other horrible things that were done. This also corresponds to palliative and treatment for diseases that affect exclusively people of color, right? And so for a really, really long time, there was really nothing done about sickle cell, no real effort put into it. And really the only treatment that you would get if you had a particularly progressive doctor would be inhalation of nitric oxide. I have something to tell you about the inhalation of nitric oxide. It doesn't solve the problem. All it does is it makes you slightly lightheaded, and so you forget about it hurting until you leave the doctor's office. Okay? Not a treatment. Pretty shitty thing to do, right? We're really, really only starting to see actual efforts put into trying to deal with this. And really the most promising ones have to do with this hydroxyurea treatment. And what hydroxyurea is doing is it's stimulating your body to produce a different form of hemoglobin called hemoglobin F. Hemoglobin F is the hemoglobin you make in utero, right? F here stands for fetal. Okay. In people that are that have sickle cell anemia, it's only the adult form, hemoglobin A, that sickles. So hydroxyurea induces them to produce this non-sickling hemoglobin F, which is suboptimal for adults, but it's also better than sickling red blood cells. So that's really the most prominent, I guess, and promising treatment for that. Gene therapy, not so much. Gene therapy really isn't going anywhere. In general, there are very few positive treatments for gene therapy that we've noted. Stem cells, again, not as promising as you might imagine. There are a lot of complications with stem cell transplants that aren't with something like hydroxyurea. And just for the record, in case you were curious as to what these things look like, normal red blood cell versus sickle red blood cell. Again, the only difference there is the lack of oxygen bound to that hemoglobin. There are a handful of other things here that affect erythrocytes a little more directly. Polycythemias. There are polycythemia vera, or true polycythemia, or secondary polycythemia. Here our issues are of too many red blood cells. So rather than having an anemia, we have a polycythemia. Poly here, right? Many cell, anemia, blood, many red blood cells. Okay. Polycythemia vera is typically associated with cancers of the marrow, basically. If you are unfamiliar with what a cancer is, all a tumor is unrestricted cell division and cell growth. And so if that unrestricted cell division occurs in a population of, say, committed red blood cells, right, so our pro-erythrocytes, well, then we're going to have a huge amount of red blood cells at the end of it, right? And the issue here, right, is the same as the issues we've talked about before. Too many red blood cells leads to blood that is too viscous, right? Going to lead to cardiac problems down the road. Secondary polycythemia is not quite as severe as this, obviously not cancer, right? And secondary polycythemia is what you'll experience if you travel to someplace at a high altitude. Lack of available oxygen is going to up your red blood cell count, and that's perfectly normal and expected and not necessarily problematic. However, though, as we discussed, right, artificial EPO or packed red blood cell injections, blood doping, both of those things, if not done carefully, and they almost never are, can also lead to some of the problems that we associate with polycythemia. There. Okay. Obviously, the other major issue we would expect to encounter in a clinical sense with regard to the blood is trying to keep blood inside of your body. Now, again, I'm assuming that nobody here is superhuman. All cut yourself at various points in your life. If not, please tell me. I'd love to know about it. And in the process of doing that, obviously you did bleed out and die, right? You're here to take this class for better or worse, right? So there has to be a mechanism by which we stop bleeding from happening and allow time for the healing process to begin. This is called hemostasis. And it involves a number of different proteins, things we call clotting factors, and we're going to really condense this down. There will be other courses where you learn a lot more about it. Here's not one of them. the impact of platelets, and then the impact from there of fibrinogen. Okay. Everything in total is going to be kind of a really simple three-step process. We're going to begin with what we're going to call the vascular spasm. That's exactly what it sounds like. We're going to bring our platelets in, form a temporary plug, and then we're actually going to form a clot, scab, if you prefer, the process of coagulation. The vascular spasm is just vasoconstriction. Right? A spasm is just a contraction. Right? So a vascular spasm is a contraction of that circular layer of muscle on our blood vessels. Triggered by obviously damage to the tissue of the blood vessel itself. Right? We're also going to see that damaged tissues release, for lack of a better word, something called Schreckstoff, which is sort of a cue that cells have been damaged. Okay? So that's a chemical signal there. Or activation of a nociceptor, or pain reflex can also be used. It's pretty simple as an idea, right? If we have a broken blood vessel, we want to have as little blood flowing through it as possible to bleed out less, right? So we shrink the vessel down. It works better. I wouldn't say it works great in any case, but it works better the smaller the blood vessel is. So if you nick your aorta, good luck. Right? Vascular spasm isn't going to do anything. But if you have a more distal artery, it can work pretty well. But it's just kind of a temporary slowdown. It's like putting a yield sign up rather than a stop sign until we can get a platelet plug here formed. We talk about feedback cycles a lot in both AMP1 and AMP2. Generally speaking, right, we talk about them being negative, right? So we have a problem. Say your blood pH is too low, right? So we dump a bunch of bicarbonate in there, we raise the pH back to where we'd like it to be, and that shuts off the production of bicarbonate, right? With platelets, we have a positive feedback cycle. Right? It's sort of like a big pyramid scheme. If you want to think about that, right? They're all trying to sell you essential oils and yoga pants, right, on the internet. We get one platelet here, right, and that's going to attract two more. Each of those platelets is going to attract two more. Now we've got 7. Each of those is going to attract 2 more, and now we've got 21. Right? We're going to grow and grow and grow and grow and grow. We're not going to have that shut-off point. We're going to, the more platelets we have, the more platelets we attract. Okay? And what they're going to do, right, remember these are basically fragments of cell membrane. Right? They've got sticky ends on them. And so damaged or cut tissue, right, these things are going to stick onto those. And they're going to stick onto each other. And eventually we're going to kind of get this swollen mass of platelets that's going to form a plug, right, in the gap, assuming that the gap is relatively small. Right. Now, if you want to remember, there are things like von Willebrand factor, they're involved here. If you want to remember that, that's awesome. I'm not going to worry so much about that. Just the basic idea of what platelets are doing here, that's really more of the big thing for me. Okay? Now, again, this is a little more effective than the vascular spasm, but it is still a temporary measure, right? Stopgap, absolutely, until we get into the process of coagulation. Coagulation is going to be a little more stable over the long term. Okay? And what we're going to do is we are going to, through a fairly elaborate process, basically create a network of connective tissue fibers, okay, that are going to connect the broken margins of your wound. They're going to pull them closer together, okay? And in doing so, they're going to trap blood, red blood cells in particular, right? Squeeze all the fluid out of it, okay? And form a fairly hard, robust lump, okay, in the space, right, where that wound was, so that we can heal it. It's called a coagulation. It's called a scab, whatever you want to call it, a clot. Okay, but again, a little more stable, a little more permanent. When we get to basically this point, okay, we constrict, right, our blood vessel, we have our vasospasm, call in our platelets, like calling all their friends, and form a flux well here, so to speak, right? Long enough for us to start putting in this network of fibrin, this protein fibrin, in there to form this plug. Now, this is where things get complicated. And again, we're going to cut it down. Okay. So there's a lot of terms up here that I'm going to throw at you that you want to know them. They're kind of there if you're curious about this sort of stuff. But I'm not going to be worried about a whole lot of them. Okay. I will let you know specifically which things I think are important. Okay. So this slide, I would say, reasonably important. Okay. We have prothrombin activator, okay, which does exactly what it sounds like. It activates prothrombin. Right? And by doing that, it converts it to something called thrombin. And then thrombin, excuse me, comes back to our friend fibrinogen, which we talked about as one of the fibrous components of plasma. It converts fibrinogen to fibrin. Fibrin is ultimately what's going to form our thrombin. So prothrombin activator, prothrombin to thrombin, fibrinogen, fibrin. Like I said, there are more than a dozen clotting factors that we could talk about here, but we're not going to. And ultimately, what we get is something like this. So here we have in these tan colors here, this is fibrin, right, forming this kind of net or mesh, which you can't see outside of the viewing area here, is that it's connecting the margins of the wound. Okay? And in this mesh, we are having blood in all its constituent parts, particularly red blood cells. At this point, we're going to begin what we call clot retraction. So we form this fibrin net, right, and there's plasma and blood cells and just stuff in there, right? Not exactly what you would call stable, clotty, scabby stuff. So what we need to do is we need to do two things. Number one, we need to make the wound as small as possible. We're going to pull the edges closer together. We're going to squeeze all of that water out of it, right, and all the liquid stuff out of it. We're going to make it as hard and dry and stable as we can. That's what clot retraction is. We're simply just pulling the margins of that wound. We're taking, I'll come back to this. We're taking all of this, right? We're just squeezing down, squeezing a sponge. We're getting all the plasma and other stuff out of there, and we're left with just essentially just fibrin and red blood cells, which is going to be what we typically associate like with scab, right? They're sort of a dark red color typically, right? The red blood cells that are trapped within this clot. Okay. And this then is, like I said, sort of our steady state, our stable state, where now we're not in danger of continuing to bleed. The wound is not going to continue to move, right? It's being held relatively firmly in place, and we can begin to actually repair, right? We can actually now begin the process of putting this stuff back together in a more permanent sense. And so then we get to vessel repair. And this begins to happen roughly along the same time scale as clot retraction does. There are a couple of different growth factors here that are important for us, PDGF and VEGF. If you want to remember those, that's awesome. I'm not going to ask you to remember them. But each of those growth factors has a slightly different role in terms of what parts of, in this case, a blood vessel, are we regenerating. Right? So the PDGF is about smooth muscle predominantly. VEGF is more about the endothelial linings in the blood vessel itself. But again, both working to kind of replace the cells that have been damaged. As vessel repair progresses, or tissue repair in general progresses, we're going to run into a problem. We are putting in new tissue, new cells, right? But where we need to put them is where the clot is. Right? And so we have to remove the clot at the same pace that we put in new tissue. That process is called fibrinolysis, right? Where we remove fibrin. And this again, you can track the margin of this as we add new tissue, we remove the clot kind of at the same pace. And here, this is something I would like you to remember. Our enzyme that's responsible for this is something called plasmin. Okay. So plasmin is going to be actively kind of removing this clot as we put in tissue behind it. Now, like everything else, potential for things to go terribly wrong is very high. And so we see a number of hemostatic disorders that range from issues where we can't stop bleeding to issues where we form unnecessary clots, kind of everything in between. If you have somehow made the wrong sacrifice to Odin, you can actually get both at the same time for the DIC. Those are the ones that really, really suck. The first set of these thromboembolic conditions come from the word thrombus and embolus. A thrombus and an embolus are both clots that form when we don't have damaged tissue. So there's no reason to have them, we just form them. This is kind of like an SAT question, so I apologize, but every embolus is a thrombus, but not every thrombus is an embolus. Okay. A thrombus is just a clot. If that clot is moving around in the circulatory system, it is also an embolus. But they don't all move around. Sometimes they're stuck. And the issue with a clot, with a thrombus of any sort, moving or not, right, is that it's something in the middle of a blood vessel. Right? It could easily block, and in fact does often, block flow of blood around it. Well, they get wedged in a small blood vessel, and that's all she wrote. Okay? At that point, we arrive at an embolism. Anytime we have an embolus that actually blocks a vessel. And so you'll hear about, you probably have heard about things like pulmonary embolisms or cerebral embolisms, where a blood vessel in a lung or in the brain have been blocked by an embolus. And depending on how long the block lasts, it could be anything from unpleasant to tissue death. Particularly with cerebral emboli, the issue of body death is pretty high. Right? You can't starve your brain of oxygen for very long and expect to come back from it. So brain damage kind of at the best, death kind of at the worst, typical consequences for cerebral embolisms. If you are at risk for these sorts of things, there are any number of anticoagulant drugs you can put on. You will see aspirin kind of touted as something that we give to people, particularly that have a history of cardiovascular disorders. It's a surprisingly effective blood thinner. I don't know if you watch professional wrestling at all. When I was a younger person, I did. And one of the things that professional wrestlers often do is when a big super match is coming up, they will intentionally bleed to make the match seem more dangerous or whatever. They do so, they smuggle a razor blade wrapped in tape under a wristband or something and cut their forehead. It's not that exciting. But before the match, they will often take an aspirin or a couple of aspirin and get massive amounts. I mean, head wounds bleed anyway, but massive bleeding from a relatively small cut. It looks very impressive, I suppose, but in the long term, isn't really what you get. In a surgical or clinical setting, very rarely outpatient, we use heparin. Heparin is often a pretty typical pre-op drug being given, again, just to prevent clotting during surgery particularly. If you watch a lot of golf or other old white guy programming, you will see ads for warfarin fairly commonly, or less commonly nowadays, the Vigatran. These again are outpatient type drugs for people that are maybe in need of something a little more intense than aspirin. The other side of the spectrum is when we have a bleeding disorder, so we can't form clots at all, or sufficiently, I guess. So rather than forming too many clots, we can't form enough. And typically this is thrombocytopenia. Again, we talked about anemia before as being not enough, right? Not enough thrombocytes, not enough platelets. And so a really common presentation of thrombocytopenia are these little pinprick bruises, particularly on the upper thigh, on the torso, on the forearm, called petechiae. Petechiae are just little bruises that form because you have ruptured capillary beds. Again, happens all the time. Capillaries are really, really weak. Normally they clot and you don't get bruises forming from them. If you can't clot, you dig as a result of that. As to the root cause of the lack of platelets, there can be any number of different things that go into this. Typically, we associate this with problems with the marrow itself. You might be on radiation treatment for a cancer, ironically enough. You might have been exposed to radiation for some other cause. You might be on any number of suppressant drugs that go into that. So ultimately what they're going to get out of this is a really, really low platelet count. Something below 50K per microliter is diagnostic. Reasonably easy to treat, and that we're just going to give you a bunch of platelets, right? But issue here is A, you're not making your own, and B, platelets don't last very long. And so you have to kind of continuously get platelet transfusions. Continuous transfusions run the risk of bloodborne disease infection, so it's not a great thing. Other root causes of bleeding disorders might be cirrhosis, other liver issues. Okay, here the issue is you can't make some of the chemicals that are kind of precursors to the process of coagulation. Okay. So again, cirrhosis is a big one. Hepatitis, another big one. Anything that's really going to affect your liver function can lead to this. And then finally, probably the one that is most familiar to you, at least in terms of a pop culture sense, these are the hemophilias. And they're really there's more, but there's really basically three kinds of hemophilia. They're all hereditary, they're genetic disorders. And they're slightly different in terms of which clotting factor you don't produce. Most people that have hemophilia A. It's about 80%, give or take. Okay. Hemophilia B, hemophilia C, less common. Hemophilia C is the most mild version of this. Hemophilia A is the most severe version of it. They're not the sort of thing where if you're a hemophiliac and you get a paper cut, you're dead, right? It's not that you can't clot at all, it's just that it takes you a really long time to do it. Okay. So it's not quite the severe thing that people often think of it as. It's not great, right? But really the biggest issue that people that have hemophilias have with the disorder is joint pain. One of the really common presentations of hemophilias is bleeding into the joint capsule, which is extraordinarily unpleasant, I'm told. So it's not great. Again, here, in terms of a overall life expectancy kind of issue, like with any transfusion-based problem, the risk of bloodborne pathogens gets really, 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 really high. Okay, so again, it's one of those things that you have to be aware of with these sorts of disorders. And then finally, the real shitty one, DICs, disseminated intravascular coagulation, DIC. This is when both of these things happen same time. So you are making all of these thrombi, right, all of these unnecessary clots, and you're using up all of your platelets. And then you actually get a cut, and you have no platelets to do it, so you have a bleeding disorder on top of it. It's a really, really, really common complication with pregnancy. A lot of pregnant women end up with DICs at some point in their pregnancy. Septicemia, again, another really, really common factor for DIC. Incompatible blood transfusions, again, same kind of deal. So not as uncommon as you might imagine, really, really not fun to have. Okay, so we've mentioned transfusions a couple of times here. I think probably you know what a transfusion is, at least in a general sense. Although I would suggest that the transfusion you're probably thinking of is not nearly as common as you might imagine. Whole blood transfusions are not really all that common outside of an emergency room trauma context. Okay. And in fact, typically when we have wholesale blood loss, what we do is instead of blood, at least as a triage measure, you get saline, right? You get a Ringer solution, you get banana bag, you get some other fluid rather than blood. Okay. So whole blood transfusions, not really common, and certainly not a immediate triage step. More commonly, we get transfusions for people that have, say, a bleeding disorder, right? And so you get packed cells, right? Packed platelets or packed red blood cells or anything like that. And part of the issue, particularly with trauma med, and one of the reasons we don't immediately hook you up to a bag of blood, is that if we give you the wrong one, that's it. It will absolutely kill you. And it's been one of the grand successes, I think, of modern medicine that we can do this at all. So you might imagine, right, that in ancient times, people would see somebody that lost a lot of blood and think the obvious thing. This person needs more blood. Let's give them more blood. Right? Depending on what point in time we're talking about, this might be human blood. It might be pig blood. It might be horse blood. Napoleon's doctor famously tried to give many people horse blood transfusions. They all went about as well as you might imagine, which is to say not well at all. And it was a sort of great idea that kept coming up. So people would try it, their patients would die screaming in agony because this is not a fun way to die. And then they'd say, well, I guess we can't do that. And they'd give it up for a while. And then 50 years later, they'd try it again. And then the same thing would happen, and on and on and on and on. And well, why the hell wouldn't this work, right? But the missing part of this was that people prior to our sort of modern understanding of blood transfusion didn't know anything at all about the immune system or about cell signaling molecules or any of this stuff. Right? So they had no idea why on earth blood wasn't just blood. What we know now is that we can separate blood cells out by what glycoproteins they have on their cell surface. What name tag do they have on the surface of their cell? And so we talk about blood groups, right? Because in a general sense, right, there are only a handful of different kinds of glycoproteins that red blood cells produce. Okay? And of these, there are really only 3 that are meaningful in an immunological sense. What this means for us is that if you have the wrong name tag, the body does not perceive this as being a blood cell, perceives it as being a foreign invader. They attack it. Okay? We get clumping or clotting, right, which is where the first part of the DIC issue with the transfusion comes from. And the blood cells are not useful to you, they're dead, right? And they also form thrombi. That can also kill you as well. So generally speaking, if you have the wrong parts, it's not going to do you any good at best. It's going to kill you at worst. The first of these name tags, these glycoproteins that we discovered, were A and B. And from there we get the ABO blood groups. Whether you have presence of A, the presence of B, or neither, right? You have O, okay? Or sometimes you have both A and B, and you have type AB blood. And this, once we understood this, this was pretty good. We stopped killing people quite as often. Right? It was successful enough that we thought, well, let's do this. Right? So let's keep on with this. From this, we were able to also discover that there are two very special types. Okay? Type O we consider to be the universal donor. You can give type O blood to anybody, which is why type O blood is so very important in blood bank. You give type O blood to anybody because it doesn't have A or B, okay? So it doesn't matter what type of blood you have. The immune system is looking for the wrong name tag. If there's no name tag, it doesn't care. Right? It will just move on with its day. Okay. The other special blood type is type AB. If you have type AB, it don't matter what kind of blood you're given, you're fine. Because you have A and you have B. So if they give you type A blood, it doesn't matter because your immune system is supposed to look for type A. You've got it. They give you type B blood, same deal. It doesn't recognize a B antigen as being foreign. As they give you type O, of course you can take that because there's nothing on there at all. Either one of these two is breathing. And the way that we test this is the last thing we'll talk about today. The way that we test this is really quite simple. Right? We get a blood sample, 2 drops of blood from somebody, right? And we mix them with antigens in a body against A or B. So here, right, in this column, we have anti-A. Here in this column, we have all A. And depending on which of these blood reacts with, we know which of those antigens are present. So in this case, right, when we put a drop of blood with anti-A and the anti-B, we have a reaction both times with this clumping or coagulation both times. So we know that both of those are present. Type AB blood. Type A, right? We only have the reaction of the anti-A. We have nothing happening with the anti-B because B is there. And vice versa with type blood. And of course, type O won't react with anybody. So, really, really, really easy testing procedure to be done. Okay? When we're not in a pandemic, we do this in lab. We're in a pandemic, so we're not going to do it in lab, but easy to do, nonetheless. Okay? All right. I'll see you guys on Monday. Have a good weekend. We come back, we will talk about the other blood group, the reason that people still died from blood transfusions prior to our discovery of it.